Professor Anna Novak-Wegrzyn, talking about clinical implications of 2'FL and LNT in the nutritional management of cow's milk allergy.
Just touch it. Okay. Thank you, Alex, for this introduction. Thank you for having me today. I will be sharing some of my experience as pediatric allergist, and here are my disclosures, and I do receive honorarium for this presentation from Nestle. So here are my objectives. I'll talk about, just to refresh your memory, that cow's milk protein allergy is an immune-mediated disease. We'll talk about the role of HMOs, particularly for children with cow's milk protein allergy, and then review the evidence from clinical studies on adding two HMOs, 2'FL and LNnT, to the hypoallergenic formulas, both extensively hydrolyzed and amino acid based for children with cow's milk protein allergy. So cow's milk protein allergy is an immune-mediated disease. It could be IG-mediated or non-IG mediated, and it is one of the most common food allergens, affecting maybe 2 to 3% or even higher in the first year of life. The treatment at this point is avoidance and substitution for the eliminated nutrients. For every infant, the first year of life is the critical time for development of the immune system, and also of the maturation of the gastrointestinal tract, the intestinal barrier, the digestion, and it's heavily influenced by establishment of healthy microbiome. And we know that children with cow's milk protein allergy have also reactions in the gut, so local immune reactions, which suggest that there's a defect at the mucosal level. And very simplistically, we think cow's milk protein allergy reflects overactivation or overexpression of the Th2 immune responses over the normal anti-infected Th1 immune response, increased gut permeability, as well as altered gut microbiota, so dysbiosis. And what's relevant to my presentation is also to remind you that infants and children with cow's milk protein allergy are at a very high risk to develop infectious complications, predominantly lower as well as upper respiratory tract infections. And this is, reflective of that imbalance between the Th1, Th2, also delayed maturation of the Th1 response in addition to that imbalance. So normally there's a maturation of the immune system over the first 3 to 5 years of life, and children who are born with predisposition to A to B have much delayed maturation. What does it mean that those children have more infections? It means that unfortunately they're being treated with antibiotics. So although we know that most of the infections in infancy are viral etiology, yet children are being treated with antibiotics. So on average receive up to 3 courses in the first 3 years of life. So, and we know that, this reflects this impaired immunity, Th1 immunity, and the gut environment plays a big role in that. So maybe I'll not go into detail over this slide because Liam beautifully explained how do HMOs support the development of the immune system in infants. And this is true for all infants, but also for children with cow's milk protein allergy. So they promote healthy bifidobacteria, which are predominant bacteria communities present in the stool in the gut of healthy breastfed infants. They assist gut barrier function, so they improve intestinal permeability, so leaky gut. They provide this pathogen exclusion, so maybe that's one of the components of the protection from infections. And then, as Liam pointed out, they also have the ability to directly stimulate the immune system, either through activation of the dendritic cells that then produce IL-10 and activate the T regulatory cells, or production of other types of cytokines like IL-22. So on to the clinical evidence from the clinical trials. So the first study was a study which was done to prove that adding HMO to hypoallergenic infant formula does not change hypoallergenicity. So always whenever there's a new component added to the hypoallergenic formula, there's a concern whether there is a cross-contamination during process, during production. So it was a study that was done in the US, multi-center clinical trial, which actually included a lot of children with IgE-mediated food allergy. Those are infants and children up to 4 years of age. The test formula was Altera, and this formula has similar concentrations of 2'FL and LNnT that are found in human milk. So those are two sort of very important HMOs that are present in, I think, account for about 30% of all of the HMOs. They're very high in breast milk in the early early life. Those are selected for inclusion. And this study confirmed hypoallergenicity of this extensively hydrolyzed whey-based formula, which was actually manufactured with a non-porcine-derived enzyme blend. So I will not go over this in detail, but essentially there was a double-blind placebo-controlled challenge, which means one session of the challenge was feeding with the formula with HMO, and the second session was feeding on a separate day, was feeding with the formula without HMO, and the reactions were evaluated during the challenge. American Academy of Pediatrics had formulated or defined allergenicity for defined criteria for hypoallergenicity of infant formula, that it should be tolerated by 90% of children with cow's milk protein allergy under controlled conditions such as during oral food challenge. So we have shown that the formula, both test and control formula, were tolerated by over 98% of the participants in the trial, which were children exclusively with the IgE-mediated food allergy. So that was just one time, so it didn't really give us, we determined a formula is safe. So now onto the studies that included longer, feeding with the formula over a longer period of time. And actually, the study was designed to look at the growth in infants with cow's milk protein allergy, not specifically looking at the infections in those infants. So the new formula with HMO actually has a reduced protein level. So there is a big concern whether lowering protein in the formula is going to translate into suboptimal growth in those infants. So this was a non-inferiority trial design which compared feeding with the formula with and without HMO over several months. But among the secondary objectives, there was assessment of tolerability, safety, infective morbidity, and medication use over the study period. So it was a large multi-center clinical trial that enrolled and randomized 194 infants, 1-to-1. And there were some dropouts from the study, about 15-20%. The result was positive in terms of the non-inferiority, so there was similar weight gain and growth, longitudinal growth in infants fed with the test formula with lower protein content. There was no difference, so both formulas were very effective in helping the symptoms, because symptoms resolution across all of the time points was not different. And what was very relevant to my presentation, there was reduced frequency of upper and lower tract infections as well as ear infections at 12 months in the per-protocol analysis. So there's also some reduction in the lower respiratory tract infections and gastrointestinal infection, although it wasn't statistically significant. So the primary endpoint of the study was growth, and maybe I hope you can see the lighter green is the control formula, the dark green is the test formula, and you can see that they sort of track very closely for weight and length. But the outcome, secondary outcome of the infection reduction was also very interesting. So You can see the results of the protocol as well as full analysis set, so intention of those infants who are enrolled. By either type of analysis, there is a reduction in the frequency of the lower, upper respiratory tract infections, ear infections, also gastrointestinal infections, acute diarrhea. And looking at those infections, I should have mentioned that before studying this formula in infants with cow's milk protein allergy, there's a very interesting study that was done in healthy infants, which showed that there was a significant reduction in the lower respiratory tract infections and also antibiotic use in healthy infants who were fed with this formula since 2 weeks of age up to 12 months. In contrast, in the children with cow's milk protein allergy, those are infants who already developed symptoms before they were entered in the study, so they were enrolled at an older age, and the duration of feeding with formula was shorter, 8.8 months. So there was a relative risk reduction of 34%, but it was statistically non-significant. However, when looking at the frequency of the infections and reduction in lower and upper respiratory tract infections per month, there was a statistically significant reduction in the upper respiratory tract infections, which I think is very interesting, especially that these are the infections that are driving the unnecessary use of antibiotics and, you know, making dysbiosis worse. You know, the conclusions from the study were that the new formula, extensively whey-based, supplemented with 2'FL and LNnT with reduced protein content, supported normal growth and then resolved symptoms of cow's milk allergy within 1 month. And it suggested that there are some immune-enhancing properties of the formula supplemented with HMO in reducing the respiratory and ear infections. So Professor Heine is going to really show you the impact of those HMOs on the microbiome and the metabolome in the study that I have just discussed. So this was an extensively hydrolyzed whey-based formula. Now on to a amino acid-based formula. Just briefly, this was a study from Australia, which was an observational single-arm study, again in infants with the mixed picture of both IgE and non-IgE. So the outcome was growth of infants with moderate to severe cow's milk allergy who were fed amino acid formula with HMOs. This is the same concentration of the HMOs. And since it was a single-arm study, the growth parameters were compared to the WHO growth standards. The population of the study was 32 infants who were enrolled about 4 months of age. There's pretty good retention in the study, they were follow-up up to 12 months of age. So I think what is interesting in the study is that the manifestation, so both IgE apparently and non-IgE, although we don't have the results of the IgE testing, by looking at the types of the symptoms, there was urticaria, angioedema, but the vast majority of the symptoms were either gastrointestinal, so rectal bleeding, irritability, vomiting, or eczema, atopic dermatitis, so very common manifestation of cow's milk protein allergy. So growth parameters were, so the blue line represents the study infants, the red interrupted line represents the standards, and you can see that they sort of track nicely over the study period. What was also very interesting was this very prompt symptom resolution. So you can see at baseline a lot of crying, fussing, spitting up, vomiting, feeding problems, skin symptoms, and respiratory symptoms. And then over the first month after initiation of the treatment with amino acid formula with HMO, there was significant reduction in all of those symptoms. So just as a reminder, formula without HMOs also reduced the symptoms in the infants fed with extensively hydrolyzed whey-based formula. So the summary of clinical results of the platypus study is that infants with moderate to severe cow's milk protein allergy, both IG and non-IG mediated, fed with amino acid formula with 2-HMO, achieved normal growth with some catch-up growth. During the 4 months of study period, all our anthropometric parameters progressed along the WHO growth reference. Significant clinical symptoms decreased significantly from enrollment to the 1-month follow-up visit. So pretty rapidly, there was a significant improvement. And I should mention that the formula was very well tolerated. There was no adverse events, and there were just 2 infants that reported some abdominal discomfort, but that continued in the study. So clearly, the formulas are having some beneficial effects in infants with cow's milk protein allergy, and Professor Heine is going to take over and tell you why and how this is happening. So in summary, although I didn't talk about lactose, I should mention that it is also a very important component in the human milk. And in addition to HMO, is important for development of the healthy immune system in breastfed infants. And the formulas that, until recently, hypoallergenic formulas did not contain lactose and did not contain any HMOs. Development of allergic diseases is complex, and there are multiple risk factors, but microbial dysbiosis is one of the important risks. Cow's milk protein allergy is immune system mediated disease, and the 2'FL and LNnT play a role in protection against allergic disease through several actions. Both whey-based and amino acid-based formulas supplemented with 2'FL and LNnT were tolerated well, resolved symptoms, and maintained normal growth, supported normal growth despite lower protein concentration. It does have a positive influence over the microbiome and metabolome of the gut in those infants. Thank you.
Thank you very much, Anya, for this really lovely presentation. Thank you.